And now I would be speaking about the primary surgical management once you've identified a benign versus malignant tumor. How do you manage? I work in Bangalore with Narayan Netralaya. So excision biopsy is the commonest procedure for management of eyelid malignancies, but rarely an incisional biopsy may be required, where it's not very certain as to what the tumor is, whether it's benign or malignant. So in a lesion which looks like this, you might want to take a small incisional biopsy from the junction of the abnormal and the normal area. And of course, before any major destructive procedure is done, this is a basal cell carcinoma extending into the orbit. But definitely an incisional biopsy and histopathology proof is required before you proceed to an excision. In a primary excision, we need to make sure that we decide on an adequate clinically free margin when we are excising. That might mean you're sacrificing some important structures, such as the lacrimal canaliculi, and you have to talk to the patient about that. And we actually have to decide whether we are taking out the entire tumor or not. Externally, it might look it's just this much, but when you pull the lid down, you can see the tumor extends right up to there. And this is a basal cell carcinoma with telangiectasia and ulceration in the center. And so ultimately, even for this lesion, this is actually the extent of how much you're going to excise. And usually it's best to mark it out before infiltrating anesthesia and put the lid on stretch. Most of the times I prefer to use cold steel, even though a radio frequency can also be used because it has less collateral thermal damage. When you're cutting this, try and use straight scissors and try not to shelve the edges because you're trying to get equal margins on all sides. And you can see that the corneal shield is in place while you do all this. So the aims are having adequate clinical margin, avoid crush artifacts on edges, don't handle the edges as far as possible, and avoid heavy cautery burns. And why are we talking about 4 millimeter margins? So this is a study which comes from the dermatologists. And essentially our aim is to have tumor-free margins. And if you have 2 millimeter margins, only about 70% is tumor-free. When you go to 4 millimeter margins, you get 95% tumor-free margins. And that is our rationale for having this amount of margins. And why exactly do we want histopathology and tumor-free margins? Well, before these protocols were applied, the mortality rates went up to 36%. And after this particular procedures have been applied with the newer techniques, the mortality rates are 1 to 2% for squamous cell and basal cell carcinoma, and they've come down significantly to 11% for sebaceous carcinoma as well. And when we are sending the histopathology, we usually try to take the edges and attach them separately. They're stitched onto a filter paper and marked for orientation, T for temporal, N for nasal, I for inferior. And the standard procedure is we used 10% formalin and the volume of formalin about 10 times the volume of the specimen. We need to communicate clearly with the pathologist along with the important information and the professional diagnosis and orientation. What happens if we don't adequately communicate? This guy turned up with preauricular lymph nodes and temporal invasion of a sebaceous carcinoma who'd undergone a biopsy 2 years prior. And the pathologist there had said foamy histiocytic infiltration with inflammation. Okay, obviously whoever did the biopsy did not talk about the possibility of a sebaceous carcinoma to the pathologist. And a general pathologist is not so used to looking at ophthalmic specimens. So this is where it is very important you develop a rapport with your pathologist and communicate. The other main recommended procedures are Mohs micrographic surgery and excision with frozen section control. And this is level 1 evidence for squamous cell carcinoma, basal cell carcinoma, all sebaceous carcinoma, all malignant melanoma, and all medial and lateral canthal lesions. In Mohs micrographic surgery, the gross tumor is removed and thin layers of tissue are removed from the edges, marked, and each a bit of tissue from each point is tested again. So the positive areas are marked, and that area is re-excised, and this keeps on repeating till tumor-free margins are achieved. So a Mohs surgeon is different from the final reconstructing oculoplastic surgeon. However, in a frozen section control, the edges are mounted separately and the pathologist can evaluate. So there are certain differences in Mohs and frozen section. For us, a very important point is there is a conflict of interest when the same surgeon is excising and reconstructing. So we need to be very conscious that we are definitely taking the entire margin. And where neither is available, a delayed closure after permanent section confirmation is appropriate. There's no significant adverse effect. Suppose you take an excision and send for permanent section, that will take about 3 to 4 days. It's perfectly acceptable to patch the eye till you know that the edges are free, and then you might need to do a staged excision. And in fact, for morpheoform basal cell carcinoma, that might be better, as well as for sebaceous carcinoma, where there may be artifacts on the frozen section. What happens when malignancy is detected in unsuspected lesion and the edge clearance has not been done, such as this patient who turned up with this little notch where something had been removed? Well, you can still take margins from the suspected area of the lesion and ask for clearance. So the ancillary procedures include conjunctival map biopsy, and all suspected sebaceous carcinoma should be undergoing map biopsy of conjunctiva, where you take bits from the conjunctiva and mount it on a piece of filter paper with marked for excision. And this identifies residual disease to plan excision, cryotherapy, or topical chemotherapy, or even exenteration. So eyelid malignancies are easily detected and identified, and when managed correctly, they show a good prognosis. There's no reason at all that any eyelid malignancy should be allowed to proceed to this stage. Thank you.